Hey guys, can you hear me?
Yeah, Sunil, Dave
Morning,
here. We
Sunil.
can hear you. We can hear you great. We got about 32 minutes, so we're going to give you all the way to 9:45. Okay.
Fabulous. Great, thanks so much. It's great to interact with you guys. We've got a terrific case here. We've got a great team. I'm here with my colleague Manesh Patel. I'm going to have him do some introductions here for the team that we've got in the room.
Thanks, guys. It's always a pleasure to be part of this. We have Diane in our room with us as our nurse, and we have Marcus on the table with Willie, and Samit Subarwal, one of our star fellows, who's actually still looking for a job out west, if anybody's interested. I'm going to show you all the stuff he did here today. That's great. If we go to our slides now, I'm going to show you the case we have for you today, and I think you guys probably talked a lot about it. I might just walk down.
So we've got a terrific case for you here. One thing I do want to say, though, is that, I want to congratulate Dave Ryzik on this 9th annual course. It's a terrific honor for us to be part of this. It's really difficult to start putting these live cases together and putting these conferences together. If you go to the next slide, I don't know how many of you know, but Dave's also had to struggle his whole life with being a Michigan fan. And these people lead lives of quiet desperation. So just as a public service announcement, I want to just ask everyone out there to befriend a Michigan fan. It'll hurt you more than it helps them, but I think it'll help us all come together. So just keep that in mind. And I'll turn this over to Manesh to start talking about our case.
Go blue, baby.
All right, so if you show us the... This is a patient who we actually met about 4 days ago. He's a gentleman who presented with acute chest pain and an anterior STEMI and was transferred about 40 minutes away. He had a past history significant for hypertension, hyperlipidemia, and some prior substance use. Go to the next slide, please. Unfortunately, he actually had discomfort at night at 2:30 a.m. and stayed home for a little bit until about 4:30 p.m. the next day, so a good 12 to 14 hours. Was eventually brought it up with his family, brought in, and had an anterior STEMI at Duke, was hemodynamically stable. You can see some of the vitals here when he showed up. Had been reloaded with clopidogrel, brought here in about 35 minutes, and we're going to show you some of the pictures here next. So the right coronary didn't seem to have much disease. The next slide. You're going to see that there's sort of a ostial LAD occlusion, and we're going to talk some about that, and then the bifurcation disease, you see some in the circumflex. Next slide. Again, sort of stumped with a fair bit of disease in the other vessels, including the diagonal. I'm going to let you see it one more time and then go to the next slide. So was a little bit difficult to wire because of that diagonal, but we wired the vessel and balloon and stented this and post-dilated it up, and you can see that it's a chronically diseased vessel. Next slide. You may have one more picture with the stent going in. I think this was taken up to about 3.2, 3.1. Next slide. A very large proximal LAD with the taper, but you can see sort of the result on the left here. And show that slide there too, please. So we felt like we'd done pretty good, and like most institutions, we're trying to get our patients home in a few days afterwards, but I think there's one thing here we'll show you that made us a little bit more concerned. Next slide.
Oh, geez. I'm sorry. How did that get in there? Sorry, wrong slide deck.
So here's the ventriculography we performed at the end of the case. The EDP was about 24, but given his late presentation, we wanted to make sure there wasn't some other structural issue going on, and obviously you can see he's at least taken potentially a large anterior hit and a fair bit of MR.
Sunil, Manish, great job. We're going back to
case.
Scottsdale now because anytime you put up a equals M sucks slide, I've got to get you out of here, man. Just kidding.
All right. Yeah, well, I don't know how that got in there. Next slide. So a day ago, he goes into atrial flutter. We're thinking about trying to, get him diuresed and afterload reduction, and starts to have a fair bit more pain on the wards over the next 24 hours. So he's been brought to our lab for consideration of, I'll show you the circumflex, what we were thinking about. And then he's also had atrial flutter, and there's a conversation going on between us and the rounding team about anticoagulation plan to do it.
There you go.
So let me show you those. One more slide maybe here.
Going up.
Just start our live cases here. We have 2 cases for you guys today, and we're obviously still pretty excited about how things went yesterday. So if you go to the live feed, if you guys come off floor, I'll show you. We've been doing some work, and we wanted to see if you guys think we've been doing the right things. So we brought him to our lab with the idea of looking at this marginal system here. And let me just show it to you and see what your thoughts are. Small, very tight, sort of OM with 2 branches. It is serving the lateral wall. Maybe that's playing a role with some of the valvular things you saw. And so maybe I'll say, you know, what possible approaches you might have to this bifurcation. One of our concerns was that when we wired this, when we wired this, if we lost flow or if we were going to have some issues with wiring it. And so our initial strategy was to wire both, and then we'll tell you what we did. I don't know if you guys want to talk about that for a second. Sunil,
What's your guide size here?
This is a 6 French XP 3.5.
So it's a really small vessel. So I think one of the things you need to figure out is if it's really a small vessel or whether it's a lot bigger. And you know, IVUS, OCT, something.
Right, if it just needs some blood in it.
Yeah.
I think one thing I'd ask is, what about the MR? So you're 4 days later. Have you done a follow-up echo? Do you know the MR is still there, not there? Because I think that changes us a lot whether you approach this OM or not.
Yeah, so it's a great question. I think that's Tim. We did a MR. He actually had an echo the night he was admitted, as of many things gets a lot of tests here, and actually had an echo when he went into atrial flutter. Always hard to interpret those echoes when he's in atrial flutter, but it felt like the MR was a little bit better, actually, not much 3+. It still had, according to our echocardiographers, and looking at it, he still had some MR. We graded it at 2+, and we were still concerned about it given his ventricular function and his failure.
So, Tim, let me ask you, though. Let's say the MR was just as bad. Tell me about what your management would be then. I mean, would you send him to surgery to have the MR fixed and then graft the OM, or?
So it's a very interesting problem. I think, and the A-flutter complicates it too. What you'd want to do, before I'd approach this OM, personally, I'd want the patient to be several days out in normal sinus rhythm and know for sure they're having ischemia, because that's a huge infarct. So if you have any ischemia in the circ territory, I mean, now you're really potentially putting the patient at risk. And I think the issue about the MR is if you consistently still have 3+ MR, you know, that patient's at very high risk long term, and that's probably the biggest issue. Then I think you have to have some discussion about, do we fix the MR or not? And you don't want to do that acutely. And I think this patient, you want to get up as far out from their infarct as you can. Now, if you can't, if he's having recurrent ischemia and you can't, then you have to do it. But you want to be forced into it, I think.
Yeah. So just and add one comment. I think the demand ischemia of the atrial flutter doesn't automatically mandate revascularization. And I agree with Tim in terms of dragging your feet as long as possible before you have to get into this circ. Now, you're already committed, so I'm with you. But I didn't like that LV function very much, and at 4 days, I'm sure it's not much better.
Right.
And a pain syndrome 4 days after a massive anterior MI could be the beginning of pericarditis, could be remodeling, could be other things, and then you complicate it. Nonetheless, the small circ system with that large right coronary, I would have dragged my feet longer. Good luck.
Or just shock them, right? Just go ahead and cardiovert them.
Yeah, so the good news you'll see on the pictures too is he did yesterday about midday cardiovert into sinus and has been in sinus for the last 12, 24 hours. And
with no pain, actually. So there's a pretty good correlation between him going fast and the chest pain versus sinus rhythm at a rate of 70 or so and symptom-free.
Yeah, so Sunil, I think...
Still some discomfort. And then the other conversation about anticoagulation.
Yes.
Yes. Big anterior MI and the flutter, both.
Yeah. So maybe we'll show you what we did. Obviously, we were...
Yeah, I would argue not. I would argue
so we had
that
some of the same
risk of that is
conversations.
too high. I don't care how old he is.
The risk of PCI in the circ, you mean?
No. That the risk of Coumadin, we know the risk of triple therapy in this guy is high risk of bleeding, and unfortunately, it's always for me the younger people that have the massive bleed. So I'm like you. Let's just pop this circ and see if it's real big. Then you know you got to work on it. If it's a small piddly ass circ, then I think the issues are less complex.
Sunil and Manish, this is Manish Parikh here. I just wanted to say I think the circ is reasonable. This guy had ischemia with rapid rates, but also in your RAO caudal, the diag you left is not a small diag and it has a tight lesion as well.
Yeah.
Not to lose sight of the fact that there. Agree with going and treating the circ. So what's your strategy for the circ, guys?
So I'll have Manesh tell you here what we did.
So we, this you're going to see. So we wired both both branches of the circuit. You're going to see. Nice job, sort of getting through some of those spots there. And then our thought was that we would try to balloon and give nitro to see how big this is going to get. And I'll show you some of those pictures. So that's wires in both. This is initially a small 1.5 and then 2.0 balloons. You're going to see us do a 1.5 in this section because it's so small.
So we're TR or
you see it start to get a little bit bigger.
Half of our said.
TR, of course.
Sorry, we were in the right radial.
As Bob Applegate showed, you can do complex cases TR. Even though I beat him in the debate.
And then you see here we're. So we then are pre-dilating the inferior branch here with a 2.0 balloon in a few locations to sort of get as much. So here's a view that we had a few minutes ago while we were waiting for you guys, thinking about different strategies. And I'll show you that we elected to stent that inferior branch from sort of somewhat normal to normal if you can, thinking that we would provisionally rescue the superior branch if needed. And this is just one more pre-dil balloon, and I'm going to show you the stent, which took a little bit to get down there, but not a tremendous amount.
So the question, I guess, for the panel is, do you guys, what are your thoughts on the shortened DAPT stuff with some of the newer platform DES? As you know, the Zion stent has CE mark approval now for 3 months of DAPT in Europe. Are you guys doing that? I mean, there's this mega analysis by Sripal Bangalore showing that, maybe there's equivalence or maybe even a little bit of superiority with respect to safety with some of the newer DES platforms. Are you guys routinely, 1 year to 2 years of dual antiplatelet therapy, DES?
Sahil, Mort?
Look, I'm still
good, buddy.
old school, and I'm continuing it for 1 year at the moment. I'd like to see what happens. I think shorter is better. And in this guy who you want triple therapy, a shorter would be best. But at the moment, I've not changed practice on that study.
So this is Tim. I think the issue is not the stent here. This is a patient who had a STEMI. And so the point is, if you look at the guidelines for dual antiplatelet therapy, even if you did bypass surgery in this patient, they should have dual antiplatelet therapy for a year, and they have benefits, and maybe longer. So the issue for me, and I think Jim from earlier in the day when he just showed his picture with all yellow everywhere, I think that's the issue. It's that a lot of what we're treating, it's not the stent.
Yeah.
Yeah, so he has an indication for 1 year for dual antiplatelet therapy for ACS, and then an anticoagulation decision that has to be made on top of it for one episode of A-flutter.
Or maybe the big anterior MI
and the big
as well.
anterior MI decision, right?
So the question is, who would put, would you guys use DES here? It's probably a 225 vessel, long lesion, bifurcation. Would you put in bare metal here or drug eluting? We'll tell you what we did.
What'd you put in the LAD?
So initially, it came in, we actually put in a bare metal given some of the history and thinking it was bigger and concerns over compliance.
If you want to stay with bare metal, which would be a possibility, that shortens your DAPT to weeks. Then I'd clearly try to use IVUS guidance to get it as big as I could.
Okay.
See, I would put in drug eluting. I think the evidence in STEMI supports drug eluting. I'd put drug eluting, and I would do everything possible to make sure the patient stays on dual antiplatelet therapy. Because now, if you're going to put bare metal and say, well, maybe I'm going to stop the thiopyridine, this patient's at a huge risk because now you've got a lot of stent in big territories. So this patient need to make sure that they are compliant.
Plus, why would you use clopidogrel here in a young patient? Obviously cost is one answer, but if cost was equivalent, would you guys use something other than generic clopidogrel?
Absolutely.
Yeah, so this patient arrived having been loaded with clopidogrel at an outside hospital as a transfer for the STEMI. So I think the idea was to stay with that. We ended up actually using drug eluting here for a couple of reasons. One is that the lesion length and the vessel diameter worried us about the risk of restenosis. The second thing is that, I think it was John who mentioned the bare metal in the anterior wall. If you look at the flow in the LAD here, I mean, it really, and then as well as the wall motion abnormality in the acute setting, I mean, I really wonder how much of that anterior infarction is transmural at this point. And I think our goal here is to salvage the posterolateral wall of the LV. And this is actually, although it's a small caliber circuit, it's a pretty long circuit and supplies a fair amount of myocardium. So that was our strategy. And you know, we agree with Tim. I think trying to encourage adherence with doing antiplatelet therapy to the best that we can is probably the way to go here. Again, outside of the stent issues, really for secondary prevention.
So why don't we show them what we have and then see what their thoughts are. So, so we did put this stent in, and now here's a couple of views of where we are after this 225 Xience, probably at 23, and we post-dilated it up to about 234. Let me play that. I apologize. And we recrossed with the wire on the superior branch, and so now we're thinking about IVUSing the inferior. Just look at the stent, but I think we feel as if we've treated the larger territory. Although obviously there's still this branch in the superior that we're feeling comfortable not doing more to at this point.
Yeah, I think that looks really good. And if the IVUS suggests that you're okay, then you're done with the circ.
IVUS?
Yeah, that's our thought. I mean, would anyone go after that side branch at this point?
No.
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 You do want to take it off?
Fluoro, yeah, fluoro.
That's great. So, yeah, I think we're unanimous on that. I think, again, IVUSing this branch, I think will be helpful to sort of figure out if we need to do any more work. But I think we're probably pretty close to being done.
What do you guys think about the diagonal now at this point? We're going to leave him alone, obviously, try to get him home, get him on good medicines, and just see how he does. And as I think was brought up, we saw that it's the larger territory, and some would have argued potentially another important area to consider.
This is the case where I would do FFR of that, so that when I send him home, I knew what was going on there. I think more information is better. And there's nothing about that diagonal territory that would preclude getting an accurate FFR read right now.
I mean, the diet came off before the LAD occlusion. So
John,
theoretically viable. So
Yeah, that's the only point I was going to bring up is that it's in the setting of an infarct, but it did come off before the LAD occlusion. Hopefully it's to a different, large enough territory to make a difference.
So while they set this item, John and Mort, I'm continually confused. Maybe I'm just the village idiot, but I'm continually confused about FFR in the infarct or peri-infarct patients. I've heard different things from people that I respect. Can you two just shortly clarify this for me?
I'll give it a try. I know this may not work for you, David, but so in the acute setting, the acute myocardial infarction in the territory of the infarct, because the lesion is dynamic and the bed is dynamic, we don't recommend measuring FFR. Treat that lesion clinically. At 4 days and at 6 days, there's several studies that point out that the bed appears to be stable, and the values of FFR in that territory now equal the SPECT perfusion imaging guidance that you would get. So yes, you can use it.
How about FFR in the non-infarct?
Okay, so in the non-infarct territory, it's valid. And Bill Fearon from Stanford's group, both in the unstable angina and non-STEMI, in the non-culprit vessels, found the FFRs were positive, and if they stayed positive, they stayed that way for 3 months later. So there was stability of measurement at the time of the assessment, which was unchanged by healing and myocardial recovery in the infarct zone relative to the non-infarct. So yes, you can use it for the non-infarct vessels. The only question here if you were to assess the diagonal is how far over did the LAD infarct territory go? But I think you'd have some idea. If it's normal or not ischemic, you could probably feel good about leaving it. If it's positive, well, you still have some reason to go at it. That means the tissue in that area was viable. So at 4 days later, I think you can use the information. David, does that help you?
Yeah, I think probably what you're saying is that I guess if it's negative, I would feel better. I don't know what I'd do if it was positive in the diag with such a large...
Positive
if
means,
it's positive, it's clearly abnormal.
Yeah. So positive is a real value. It could be negative because the bed was stunned and you get a false low flow and then you have a false high FFR. But, you might wait it out at that point.
This is why I come to Phoenix.
Yeah, and the problem with the word false there is it's accurate at the time, but what more it means is if I were to measure it later, when the microvascular bed recovered and peak flow would go up, then the FFR would be lower.
Sir, we're doing good.
So it's accurate at the time, which is why you don't want to measure it in a situation where the distal microvascular bed is not, is acutely stunned or acutely in trouble, because later on it will be different.
Sunil Manish, you're not getting any axial deformation, are you?
Well, that's our concern a little bit, yeah.
Yeah, I mean, certainly we're concerned about it. I have to admit, I haven't seen a case yet, but maybe I've just been lucky. How about you guys? Have you guys seen some of that LSD?
No, but I just worried about IVUS and small vessels that are diffusely diseased. I'd be curious to see.
So what were you seeing on the IVUS?
Sure.
We couldn't see the IVUS. We saw the fleura. What were you seeing as you were trying to push it there? It looked like it got hung up.
It did. It did, and then it got stuck on the pullback and jumped. We may be able to show you the IVUS here. Yeah, here we go. It should be, do you see it on your screen, hopefully?
Yes, we do.
So you got a lot of calcium.
So here
there.
it's clearly difficult to pull this back at this point. You'll see it jump in just a second.
So that would really imply that you're stuck in a sort of angulated, calcified, very hard segment right around the takeoff of that branch.
Yeah.
And then here you go.
There it jumps.
You see the jumps right there?
Yeah, so
Just
big vessel with
post-dilate.
lots of calcium and a small stent in the middle.
Yeah.
Yeah, we're going to go post it even more now, and maybe take a 2.5/12 for me, and then we'll grow it up even more.
Yeah, I don't know about everyone else. This is Tim, but I
We can
think if you
measure
have
it here,
any resistance like that at all going through, then I think you should just stop, because I think you can get the longitudinal deformation with multiple stents, to be honest with you. And I think you don't want to push. I think that means just stop and post-dilate.
Yeah, I agree with you. I think
we're
that's
good.
true.
Sunil Manish, if
We'll
it's all right
post-dilate
with you,
this
we're
some
going to
more.
let you go back over to Scottsdale and finish up with them. Is that okay? Great job, guys. Thanks for
That sounds great.
showing
Thanks
us a
so
great
much.
case. Thank
Thanks.
you very much.